Growing up, I knew my parents were there for me. We celebrated family events. They were there for me when I was sick or needed help. As me and my sister grew up, we knew we could count on our parents. We were so proud to be their children. Today, we are there for our parents, to share in the celebration of their grandchildren or to be there when they are ill or need assistance. They can count on us. And now our parents look to us to take care of them. Hello, and welcome to Always There. My name is Michael Wilsker, and I am Vice President of an elder care agency called Always Best Care Senior Services. The agency provides in-home non-medical care for seniors and independent and assisted living placement. I will be your host over the coming months, and I will be interviewing professionals who are involved in helping the elderly and their families deal with the many issues that families face when it comes to caring for an elderly member of the family, and in addition, the specific issues that the senior members of our community face every day. Today my guest is Elaine Boyer. Elaine is a longtime psychiatric social worker trained in the Harvard Medical School system. Elaine is a certified geriatric care manager and has extensive background in working with the elderly and their families. In addition to her work as a geriatric care manager, Elaine is highly experienced in working with adults who have emotional and psychiatric issues. Elaine's practice is located in Natick. Elaine, thank you for coming on.
Thank you, Michael. I'm glad to be here.
Elaine, can you just give me an idea of what a geriatric care manager does?
Certainly. Geriatric care managers can span a couple of professions. Typically, social workers, usually coming from backgrounds of working with the elderly, end up specializing in geriatric care management as their careers move on. We frequently find nurse practitioners who become geriatric care managers, who of course bring the medical side into their work. But basically a geriatric care manager is a multifaceted individual who gets involved with families and elders or disabled adults to help them move on in their lives at a level that they're comfortable with, or to somehow be able to gather whatever strengths still exist if an elder has dementia and is faltering in their ability to take care of themselves. A geriatric care manager would come into that picture, evaluate it, and make recommendations, usually to a family. The referrals usually come in through a family, and they usually come in when an individual is in crisis. Of course, the best scenario is when a family is able to make a referral before things reach a crisis proportion. At that point, we can capitalize on the senior's strengths and work to help them maintain as much independence as possible. So when we're brought into a situation, frequently a senior is living at home, alone or in a couple, and having increasing difficulty managing. They're not able to take care of themselves fully, or they're not able to follow medical orders and take medications that are necessary for them to maintain health and deal with their health issues. So in that kind of situation, which is probably the optimal situation, where it's possible to keep somebody at home and the family has resources to bring in extra supports, we would first of all call upon you, Michael, who would bring in qualified and trained aides who would work with the senior. Now, it can vary between bringing somebody in for a 4-hour shift a day to several shifts a day to round the clock. When somebody gets to needing round-the-clock aides, usually that is a situation where that person could also be in some kind of structured living situation, such as assisted living or a memory unit, which is attached to assisted living. And sometimes people go directly from their homes to nursing homes. Now that's an extreme situation. So going back to your original question, so the geriatric care manager comes in and assesses the individual's strengths, capabilities, and problems that they're having. And if that client hasn't ever been seen by a neurologist and is showing symptoms of some kind of dementia, the first thing that we want to do is to understand exactly what is going on. Dementia is a a global term. There are many different kinds of dementia, and there are different causes for dementia. So we want to understand exactly medically what is going on with that individual so that we can address those issues properly. Secondly, frequently family dynamics come into the picture. People have grown up in their parents' homes, and there are certain issues frequently that haven't been resolved among people. Everyone has family dynamics. And if the family dynamics are cohesive so that everybody is on the same page in terms of doing the best for the senior, that, again, is the best situation possible. But frequently people have different opinions in the family, and so a well-trained geriatric care manager would be adept at helping that family to resolve whatever is in the way of them moving forward and doing the very best for their parent. Frequently it's their parent. Now, go ahead.
I'm sorry, but how would you define a crisis? Do you find that most families come to you when there's a crisis as opposed to coming to you before a crisis takes place to get themselves ready? Mom and dad are getting older. Mm-hmm. We need somebody to get in there now to get us planned.
Right.
Do you find most of the time that some of the members of the family, like the children, live out of town and they need somebody on the ground to make sure that mom or dad are taken care of, have somebody looking out for them?
Right. A crisis is typically with seniors, a crisis is a situation where the senior is not able to safely maintain themselves. And things have gotten to the point where the family is either beside themselves, the senior's deteriorating, and the family is maybe in another part of the country, or maybe just not involved enough to really be helpful. So that's a situation. That's, of course, a more challenging situation. And those are the typical situations in which geriatric care managers are called in. Of course, sometimes we get calls from people who say, mom and dad just aren't doing as well. They're having more trouble in A, B, and C in their lives. And so that, of course, is a much easier picture for us to come in, plug in supports, do assessments, and work with them to make necessary changes as the senior moves forward. Now, just going back for a moment to your former question, a geriatric care manager also is involved in finding the appropriate place for the senior if it's absolutely certain that they should not be at home and the family is in agreement. Sometimes recommendations are that a senior go into some kind of living facility where they can get the constant monitoring and support that they really need to function optimally. But the family isn't ready to make that step. So, of course, in those situations, we keep the situation held together with home care. But at some point in time, that individual will have to move to some kind of a facility. So the facilities generally are there are 4 different stratas. People hear about assisted living, and I think that they think of that as one kind of facility. But in fact, in assisted living is within a residence that may have what they call independent apartments, where you either buy in or rent an apartment, and you go onto a meal plan that you buy into, and you're basically on your own. The difference between that and assisted living is that you're given, as part of your monthly fee, an hour a day of assistance with activities of daily living. If the individual needs help getting dressed, hygiene, taking medications, they can be assisted in being reminded. And then the third level of that would be a memory unit, which again is part of the assisted living facility, but for those individuals who perhaps have more advanced dementia, where they need more care and more supervision.
Right.
Once a situation is put in place and the senior has all of the supports that they need and everything is stable, a geriatric care manager would continue to monitor that situation to make sure that things are being done as they should be done, and everybody changes in time. Well, this is true of seniors too, even after they are put into a situation with all of the necessary supports.
What about the cooperation of the seniors themselves? My experience is that the seniors are the last one to come on board. They think that they can live by themselves, they can take care of themselves, they don't need to move anywhere, they want to stay home.
That's right.
And I find that at least 95% of all the seniors want to stay at home. They don't feel comfortable outside the home. And
Excuse me.
do you find that to be the highest, the most difficult thing, and it interferes with your ability to take care of the parent, of the
Well, it doesn't
seniors?
interfere with our ability, but it certainly is a challenge. So from the senior's point of view, let's take a senior who has had a relatively healthy background and starts having symptoms of some kind of dementia. So their memory is going and their judgment is faltering. And the kids are getting concerned and saying, Mom or Dad, you're not remembering this, you're not doing this. To the senior, it doesn't make any sense because they're living in their home. And they may feel, yes, I'm a little forgetful, but, I'm 80 years old. What do you expect? So let's talk for a moment about denial. Denial is a huge factor in working with these situations. Even where families have called me sometimes with an elder who has a more advanced Alzheimer's and is really faltering within the home, or it could be faltering within an assisted living situation. Even though the family understands frequently what's needed, they can't bring themselves to take that next step, which may be having Mom or Dad go into a nursing home. Which is appropriate for many people with an advanced Alzheimer's. Those people really cannot take care of themselves on any level and have many medical issues attended to it. So working with the family's denial and the senior's denial should be a large part of what a well-trained geriatric care manager can do.
Well, it's interesting because one of the reasons I got into this, into helping elders is my parents lived down in Florida.
Right.
And I live up here naturally, and so does my sister.
Right.
And we would go down there once a month. We would rotate. And my father, who just at that point, about 4 years ago, had turned 80. And he was having problems with the beginning stages of dementia. And he was falling a lot.
Right.
They had to get the emergency services there practically once a month. So I was really concerned about them. And I decided on my own to contact a geriatric care manager down in Florida. And at first my parents were saying, especially my father, oh, we don't need anybody, it's fine, we'll be okay. But I really felt more that my mother needed the help because she was the caregiver. And the first obstacle was getting my mother to agree to this. And once she did, then I got her in touch with a couple of geriatric care managers. I knew the first one wasn't going to be acceptable to my mother, and of course she called me and said, Michael, this is not the person I want. I then found another gentleman, and she said, this is the guy. And I felt that way too before I introduced her to him. It got to the point where she considered him like a second son. And he was always there. He was there at least once or twice a month. He would take vitals from my father. Gave myself and my sister peace of mind to know that somebody was there to take care of them and watch out for their best interests. He would take them, he would accompany them on their doctor's appointments, be their advocate, all this.
Yes.
And when my father turned 83, he got an infection and he was put into the hospital, recovered from the infection, then had to go to rehab, and then finally to a nursing home where he passed away. And through that whole ordeal, this geriatric care manager just did a terrific job.
Right.
And he continues to do that for us by taking and looking out for my mother.
Right.
So, that's, again, we didn't have to deal that much with the deniability. I think my parents said, Michael and Susie know what's best for us, and we're going to take care of it.
So that's an optimal situation for a geriatric care manager. Now, geriatric, I, with my background, with a very strong background in clinical work, I also sometimes have referrals from families with disabled adults. What is a disabled adult? It might be an adult with a chronic psychiatric illness who has a therapist who is on a medication regime. But, of course, the worry of families with this kind of family member is what's going to happen to this individual when we are no longer around to manage that person's lives. And that's also true of people, for example, with autistic kids. I've had adults with Asperger's referred to me who, have had great difficulty developing their lives, and I can help in all of these regards. Now, apropos of the story you were just telling me, I had a situation where a family was referred to me by an elder law attorney, and the situation was that the gentleman of the couple had refused medical treatment for a fatal condition and was dying. He had planned his path, but it wasn't working out the way he had envisioned, and he ended up in a psychiatric unit. And I was called in, and the family really had me monitor his whole medical course, which was just a situation of him slowly dying. The family wasn't around. The kids were out of state, and this man's wife was very overwhelmed with the situation. And I managed that fully for them. And now, of course, look in periodically on the woman of the couple, who is up in years, who's, cognitively totally intact, but she is in her late 80s, and, things happen, and there are safety supports that I've put in the house to avoid catastrophes, and I'm sort of the eyes on that perhaps her daughter might be if she were living here.
Have you ever had a situation, because I find it very rare, that the senior contacts you and said, I need a geriatric care manager? Is
Rarely.
It pretty much the family?
Really. I've had people call me who are living in Arizona, for example, who are saying, I want to move to Boston to be close to my kids, but I'm 83 years old,
right,
and I'm fine, but I want some help in planning for myself so that I'm not a burden to my kids. So that's a much less frequent situation, but when they come up, we embrace them.
So I take it that most of your referrals then are from attorneys, probably financial analysts who have a very close relationship with their clients who are elderly, psychiatrists. Do you ever get appointed by a court?
I don't do guardianship. I will work as a healthcare proxy if somebody has no one to do that, but I can get people in touch with attorneys or specialists who only work as guardians. I feel that there's too many overlapping issues to get involved with my clinical work. Most of my referrals come from physicians and geriatric care managers and word of mouth.
Can you just define, because I know what a guardian is, I know what a healthcare proxy is, but can you just give me some
A guardian
information on
is
that?
legally appointed by the court, and that person has legal authority to make decisions on behalf of that individual. And it's done when somebody is incompetent to make those decisions for themselves. So just as an example, apropos of elders, if you have a senior who absolutely is falling apart in their house, even with AIDS, just really shouldn't be in the house, it's not safe for them to be in the house, and the family wants to move that individual to a nursing facility where they would get the proper care and be safe. That's a situation where some people might apply for a guardianship, although there are a couple of other legal things you can do that are less confronting and adversarial. Ideally, if somebody needs a guardian, it's better done earlier in life.
And what about a healthcare proxy?
Well, I'm called in to work as a healthcare proxy, if an individual can't make medical decisions for themselves competently and there's no one else to do it. There are people who are alone in the world who need healthcare proxies. And sometimes a family might want to appoint me as a healthcare proxy because they just don't want to be in that role for, whatever the issues are vis-a-vis them and the parent in question.
Now that we're working on definitions, I've always had a difficulty understanding what the difference is between Alzheimer's disease and dementia. Can you elaborate on that?
Well, Alzheimer's is a form of dementia. It's I don't know the exact percentage, but a huge number of people who are diagnosed with dementia have the Alzheimer's form of dementia, and that is a progressive, deteriorating, and ultimately fatal disease where the brain deteriorates, starting with the frontal lobe and moving backwards. So individuals initially start having difficulty with short-term memory and falter in their judgment So what initially happens in Alzheimer's is the frontal lobe of the brain is like a filing cabinet. And so all the information that you already know and that you take in are carefully filed. Just picture a filing cabinet with multiple drawers, and within each drawer there are files that you have established. So if somebody says to you, we're meeting at such and such a place tomorrow at 5 o'clock, that gets stashed. In somebody with Alzheimer's, where that filing cabinet starts getting destroyed, people have information floating around, but there's nowhere to put it. So it's really a retrieval problem. So when an individual with Alzheimer's lives in a facility specifically geared to people with that condition, there are stimulating things that people are trained to work on with these individuals to help fortify their functioning and maintain their functioning to its maximum point as long as possible. But Alzheimer's is a deteriorating progressive disease, and ultimately people are totally unable to perform any bodily functions, mental functions, and they're just 100% total care. They end up living in nursing facilities, and the brain just shuts down at some point. It gets to the point where the brain is unable to regulate the body, and that's the point at which people usually die. Or people sometimes frequently stop eating because they've completely lost their sense of taste, and or they can't swallow anymore. But I'm talking about a very advanced stage of the disease.
Right. My understanding is that the disease is affecting more and more individuals, and it's going to grow as the baby boomers.
Well,
start
there are
growing.
just, as you know, the population of baby boomers are all aging. So there are that many more people who are going to have Alzheimer's. There are many other kinds of dementia. For example, excuse me, there's a vascular dementia. So, for example, somebody who's had a series of mini strokes might present with a vascular dementia, which is more of a, rather than with Alzheimer's, there is a focused deterioration of different sections of the brain. With vascular dementia, it's more diffuse. You know, somebody might have trouble with memory, and this point in over here may be absolutely brilliant and be able to lecture at the Harvard Business School. People with diabetes are particularly prone to vascular dementia because of the general neuropathy that goes on with the disease as it progresses.
Again, my understanding is because there's so many people now, elders that do suffer from Alzheimer's or dementia,
Or some kind of dementia.
that these a lot of the companies that have nursing homes or assisted living facilities, they've now starting to build facilities just to accommodate people who have dementia issues and assisted living.
Well, there are some assisted living residences. Now remember, assisted living, you live in your own apartment, which is, it's really sort of like a large studio room.
Right.
And you go have meals in the dining room, and there are structured activities through the day. It's a little like a country club, and there is someone available for an hour, up to an hour, inclusive in your rent, to help you with whatever you need help with. If you need more help, you would pay for that.
Right.
Those kinds of facilities, some of them are building on memory units. So in a memory unit, that is for somebody with a more advanced kind of dementia, whether it be Alzheimer's or otherwise. So in a memory unit, typically you get 2 hours of assistance a day, inclusive of your rent. And your rent probably is going to be a couple of $1,000s more a month than you would pay in assisted living.
And these are separate units. These people are not in the general population of the assisted living.
Not necessarily,
Yes.
Michael. So it may be a wing of rooms, but that those people can go into the general population of people living in the assisted living and participate in whatever they're able to participate in.
But they're secured units. So if they can only be accompanied by...
Most of them are secured units.
Right.
I know of one that was established in Wayland last year that is not a secured unit, and yet those people get more attention.
I didn't know that.
Yeah. So there are all these different levels.
Right.
Yeah. there is one in Needham that's currently being
Right.
built, and that will be a huge and secure unit.
Right. It's just there, and
That's
I've
right.
been there.
Yeah.
It's already been completed, and it's called Avita.
No, I'm not thinking of Avita.
Oh, you're not Avita.
Avita is all memory.
Oh, okay.
Avita is for people with dementia. No, I'm thinking of another unit
Okay.
that's under construction right now.
How do families or the clients pay you? Is it private pay? Can they use Medicare or Medicaid?
Well,
what is-
unfortunately, care management is not covered by any insurance. There are some long-term care policies that people may have. A few of them are starting to pay for a portion of geriatric care management, but in general, it's private pay. So increasingly, long-term care insurance should be covering care management, but it hasn't happened yet. There are a few that will pay, a portion of an hourly fee. However, if somebody just needs to come in and talk and be counseled, or get help with what's going on, some emotional support, that person could come in and bill Medicare, and that would be covered. So, but as soon as it's not talking therapy, that becomes care management. And right now, there's really nothing except a few long-term care policies throwing a few dollars at it. So that's very difficult for people
Yeah.
because, there are large numbers of people out there who don't have the ability to private pay. And geriatric care managers bill for their time, just like attorneys and just like home care.
Right.
It's all about time.
Right.
So, for example, when a case first comes in, there's a lot of phone work involved, calling other caretakers, getting records sent to you, speaking with people who are or have been involved with the individual, speaking to diverse family members. That's all billable. So I, for example, bill down to 10-minute increments so that if I'm on the phone for 20 minutes, somebody only gets billed for 20 minutes, not an hour. And I try my best to be mindful of the fact that this is expensive. And so, for example, if I have a group of phone calls that are all very short, instead of billing individually for each one is in 10-minute blocks, I'll group several of them together as one phone call.
We're short on time.
Okay.
I want to thank you for coming, and I want to thank you all for watching. And we will have other programs coming up, and I hope you'll join us then. So thank you for joining us, and have a great day.